Hey, Mike Gibson, Paul Burton coming to you live from AHA 2025. Paul, for me, I think one of the highlights, I think the highlight at AHA 2025 is the Vesalius trial. I'm one of those millions of patients out there. There are millions of us who have hyperlipidemia. We have, maybe a positive calcium score, but we haven't had an event yet. And in my mind, I think some people say, well, diabetes is a CAD equivalent, high calcium score is a CAD equivalent. But in my mind, I'm the kind of person who falls into what I would consider, in terms of common sense, primary prevention. How can I prevent a heart attack? I haven't slipped on the banana peel yet, but I'm trying to prevent that. That's what this trial addresses, and that's why I think it's so important from a public health perspective. So no one's really tested the PCSK9 inhibition question and hypothesis in people like me. So I'm really excited. Talk to me about the design and what you found, Paul.
Yeah, so thank you, Mike. Look, we agree with you. I think it is a landmark trial, a remarkable result. As you say, it takes an important question and it answers it definitively. So it takes people who are at risk for a cardiovascular event. They haven't had a heart attack or a stroke, and it randomizes them just over 12,000 people and follows them for a median of 4.5 years. So this is a long trial.
That's good, Paul, because you know, um, Michael Jackson once in his video about one of the songs, someone came in too early and he said, you know what? You got to let it simmer. You got to let it simmer. So, sometimes you get in a race to get the trial done and
Yeah,
get it done in a year and a half. And in
yeah.
a year and a half, your relative risk reduction would be good, but your absolute risk reduction isn't that great. So I'm glad you went for 4 years. That gives you the kind of events and event numbers and absolute event rates that will drive a good number needed to treat, right?
Yeah, I think that's right. And I think physicians, Mike, and systems want that kind of long-term follow-up to really be able to make treatment choices with. And, the result is remarkable, I think. Two co-primary endpoints, uh, heart attack, stroke, coronary heart disease death as the first primary, a 25% relative risk reduction in that endpoint, absolute reduction of 1.8%. And then
And
for
what does a
the
1.8% yield, Paul? I mean, how many people would you need to treat? Probably somewhere between 40 and 50 to prevent one of these events.
Yes, yes, probably. Maybe 50 to 60 to prevent one of those events. And then the other primary endpoint adds in now the need for revascularization for ischemia, and that has a 19% relative risk reduction, almost a 3% absolute risk reduction, the risk of revascularization being reduced by 36%. So really a profound, really impactful, clinically impactful result. Very good background therapy. People on a statin, ezetimibe, 75% of people on an ACE, 55% of people on a beta blocker. So contemporary study, well-controlled background therapy, and a really definitive, impactful result, I think, for these patients.
So a clear answer. Were there any positive interaction terms? Did any of the subgroups do better than others?
No, I mean, you bring up a great point, actually, Mike, because we've both seen, right, there will sometimes be questions about studies. Here, clear, consistent findings across both primaries. As you now decompose those primaries into their component parts, significant reductions really all the way through the components of
A
those endpoints.
36% reduction in MI, is that right?
Yes, high percentage reduction in MI, 36% reduction in the need for
Yes.
revascularization. So
Hmm.
really impactful. And then as you look at the subgroups as well, great consistency across subgroups. And from a safety perspective, safety event rates that are the same in the placebo group as the Repatha group.
Hmm. So, in my mind, this is practice changing. It is the first time someone's looked at this class of drugs in this kind of indication. Paul, where do you go from here in terms of guidelines, label expansion? Can you say anything about that?
Yeah. So certainly we want to talk to and are talking to, the professional societies, obviously rolling the data out here at AHA, let the community review it, give their opinion. let the societies review it, give their opinion. We'll be submitting the data to the FDA here in the United States. We'll be submitting it to regulators around the world. Here in the US, Repatha's label was updated recently to be indicated for patients at risk for a cardiovascular event. So it does
Really?
tend to
That was put in
educate.
there before this trial came out.
It was added. But now clearly this is the first and only definitive data set. We're the only sponsors to have this data set demonstrating clearly the clinical impact. So it's important. We also micro-released recently Amgen Now, which offers Repatha, at least here in the United States, direct to patients for $239 a month. So it's about $8 a day. So we really are committed to, broadening access, allowing access to all patients, and hopefully these data will be seen, as you say, as practice changing.
Well, we talk about all the p-values. There's, of course, the statistical p-value, but then there's the patient value and the price value. So I look forward to seeing, given the clinical endpoint event reductions, how that translates into value in some of your analyses.
Yeah,
Well, Paul, thanks for taking time out. Congratulations on a landmark study. I think it's going to change practice. It's going to change the lives of people like me. So thanks for joining us, and thanks for all of you out there joining us here live at AHA.
thanks, Frank.